Good morning, everyone. I'm delighted to be presenting this very exciting session, Take Control, the Science of Improving HAE Care. We are very privileged today to have here with us three of the most prestigious, dedicated, and knowledgeable HAE worldwide physicians who will share with us some of the fantastic research they've been doing. So let me introduce you to Professor Bruce Zuraw, to Professor Marco Cicardi, and Professor Konrad Borg. You will find their full bios in our program, and Dr. Zuraw will speak first. So please, let's welcome Dr. Zuraw.
Thank you, Alejandra, and thank you for the opportunity to be here, which is a tremendous pleasure for me. See if my slide comes up. Yes. How many people recognize this picture, just out of curiosity? Not too many. I picked a couple famous movies featuring Vienna. This is The Third Man, an Orson Welles movie set here in Vienna. Being here together is really very special for me. I mean, the theme of the conference is taking control of your HAE. And I'm a dreamer, and that's what's kept me involved in HAE for all these years. And control can have various meanings, as can the word cure. Because I really feel like what we're shooting for is curing HAE. Cure being not necessarily getting rid of it, but getting rid of the symptoms. I really believe that we're on the verge of patients with HAE having an entirely normal life, that the HAE should be an incidental finding that is taken care of and has no impact. And I think that's what keeps many of us motivated. We had a scientific session yesterday. The physicians have a really special relationship with the patient advocacy organizations, with our patients, and it's by working together that we're going to move this field forward. And what I'm going to talk to you about today is one aspect of the work we do in San Diego at the University of California Angioedema Center, which is the US HAEA Angioedema Center. And this work relates to an observation from the year 2000, initially made by Konrad Borg and also Karen Binkley at the same time, of a new form of HAE, where the C1 inhibitor was entirely normal, but they behaved clinically very much like the HAE that we were very well aware of. And this was really quite puzzling and remains a bit of a puzzle even to this day. And over the intervening years, well, we've made a lot of progress in defining the types of bradykinin-mediated angioedema that we deal with. And if you look at these slides, what you can appreciate is, well, whoops, I've done it. I thought that was a pointer, it's not. The hereditary angioedema due to C1 inhibitor deficiency, which is type 1 and type 2, well, we know how to diagnose that. We don't have the tests everywhere in the world that we'd like, but if we just do a better job of getting the testing there, we can make that diagnosis. Now, in 2000, what this new form of HAE, we've started to call it HAE with normal C1 inhibitor. And over the years, we're starting to appreciate that there's probably many forms of this HAE with normal C1 inhibitor. And we have at least 4 forms described right now. We have the factor 12 mutation. We have a plasminogen mutation, we have angiopoietin-1 mutation, and then we have what we call HAE unknown, because we think there will be mutations there, but we don't know which mutation it is. And if Once we establish and once we really understand each of these mutations, those will be introduced into new lab tests and it'll become routine. But at least in the United States now, the HAE unknown type is what seems to be the most prevalent, and it really causes a problem. In addition to the HAE, we have other forms of bradykinin-mediated angioedema that I list at the bottom. We have angioedema due to ACE inhibitors. That's an antihypertensive. While we can usually diagnose that, we tell people stop the ACE medication if you have angioedema. We have acquired C1 inhibitor deficiency, and we have tests for that. But then there's another form called idiopathic non-histaminergic angioedema. I have it abbreviated INHA on this slide. We can't separate that from HAE normal C1 inhibitor. We don't think that we can't figure out that there's a good family history, but we know even in C1 inhibitor deficiency HAE that about 25% of patients have a new mutation. So is it the same? Is it different? We don't know because we don't have a good test. So the best that we've had is a very now old guideline that we published in 2012, 2013, where we said, okay, we could take patients who have recurrent angioedema without hives. We measure your C1 inhibitor and it's normal. We measure your C4 and it's normal. We treat patients with high-dose antihistamines to make sure it's not the ordinary type of angioedema that responds to antihistamines. And if it doesn't respond, we either look for mutations, or if there's a strong family history, we say, aha, you have HAE with normal C1 inhibitor. But this is not a very good definition. First of all, most of the mutations probably are still unknown, which is the HAEU, and the family history can be very difficult to ascertain accurately. So again, there's idiopathic non-histaminergic or HAEU, we don't really know. And that's been really a big problem in the United States. And so it causes a critical issue for us in taking care of patients with angioedema, which is identifying patients who really have HAEU and the idiopathic non-histaminergic angioedema. And what that means in terms of taking care of patients is we see some patients who really have these problems and they don't get access to the medicines available in our country because we can't prove it. And we see other patients who are given the wrong diagnosis. The real problem is not even being investigated, and they're using lots of these medicines that really aren't very effective. So it's a very unfortunate circumstance. And so what I'm going to very quickly go over for you is a research question that at our center in San Diego we've addressed as a group, which is, can we develop a simple and reliable assay that will identify patients with bradykinin-mediated angioedema? And we start off by taking expert HAE clinicians who really understand HAE, and we have them carefully review the case records of our patients. And so we looked at 90 consecutive patients with recurrent angioedema without hives, where we thought the angioedema was real. And then we looked at a whole variety of different clinical inputs, both their history, the test results, their response to medicines. We added that in because we don't have a gold standard. So we essentially said, can we really use the best clinical data that we can gather? And then what we did is didn't just take that diagnosis, but we made sure that at least 2 different experts reviewed the data and agreed. And if 2 didn't agree, then we had a committee of 3 experts review it, and then we talked about the case until we could assign it into one of the categories. And only when we finished diagnosing the people clinically did we take the blood work that we had used for our test, which it had been coded with a random code, and combined it with the clinical information to say, well, how did it work out? And that's what I'm going to show you. So you can ignore many of the lines because we were playing with different parameters, but if you just look at the blue lines in each of these graphs, you can see that what I'm showing you is 6 different types of patients. On the top to the left would be non-swelling controls, and then the middle on the top is people with histamine-mediated angioedema. To the right would be type 1 or type 2 HAE. And then below on the left is a HAE factor 12, and then there's HAE unknown, and finally idiopathic non-histaminergic. And look at those blue lines, and you can see that we can readily distinguish the patients by this kallikrein activity identified at the dose in the blue line. And so we first asked ourselves, well, is this real? In the lab, you can have results that are real or lab results that are artifactual. So we said, does this represent the contact system being activated or the kallikrein-kinin system? So in panel A, what we did is we added something called corn trypsin inhibitor, which really paralyzes the contact system. And if we added corn trypsin inhibitor and did the assay, the blue line is flat, nothing happened. The red line is without corn trypsin inhibitor. And then on the right side, we took a patient who lacked plasma kallikrein, was genetically deficient in plasma kallikrein, and took that plasma and did the assay, and as we would predict, if we're measuring what we think we want to measure, there's no activity whatsoever. So we think that this activity is real. And this is the compilation of these 90 patients. If you look at the mean activity in this assay, you can see that the normal and the histaminergic angioedema are very low, and we get very nice separation for all 3 of the bradykinin-mediated groups we looked at, whether it's C1 inhibitor deficiency, HAE normal C1 inhibitor, or the idiopathic non-histaminergic. So we think now we can prospectively pull out these patients and say, yes, we think that you really have bradykinin-mediated angioedema. Now, one way of evaluating a test is called a receiver-operator characteristic curve. It's technical. It really just tells you how good is the test clinically. Is it going to be useful? And you can see on this little inset the different lines that go from excellent to good to not very good in blue. And if you look at the line from our assay, it really falls into the excellent range. And that can be quantitated by measuring the area under the curve, which in our case clearly puts it as classified as an excellent test. Of course, based on our clinical phenotyping, which is done independently, and this has not yet been validated by other labs, but we're hoping to move that forward. And then the final thing that I'd like to point out, and again, it's just a small point, but if this becomes a test that's clinically useful and we want to be used around the world to help identify these patients, it needs to be standardized and it needs to be easy to do. Well, it's a simple assay to do, and what we show here is that we can pick the exact right activating dose using recombinant kallikrein, because we can say, well, you need to hit a certain value and that's the amount of activator. So this is actually an assay that is transportable, that could be moved to another lab and should be able to give the exact same results from one lab to the next. And I don't want to take time that I don't have to go over this in detail, but this is just high molecular weight kininogen cleavage, an older assay, which in our hands at least is not nearly as sensitive, and the results are comparable. In patients who give us abnormal results in our assay, we get abnormal results in this assay, but it's much more difficult to do this assay. So now this is really the bottom line. If we're correct and this assay does work the way we think it does, how would we utilize it? And I suggest that what we would do is use it as a screening test in patients who have recurrent angioedema, who have failed to improve probably on high-dose antihistamines, because that's just such a simple thing to do. And then if the assay is positive, then we'd have a presumptive diagnosis of bradykinin-mediated angioedema. I should also say, I would assume that we would have measured the C1 inhibitor, and I would say a patient like that should be considered for a bradykinin-targeted medication. Then ask the question, these are expensive medicines, but now we have a reason to use it. Does it help that patient? Then we could sequence their DNA, looking for whatever mutations are known at that time, because that can be expensive. So now we have a reason to do the sequencing, and we could consider tranexamic acid or progestins for long-term prophylaxis, which tends to be helpful in HAE with normal C1 inhibitor. But if it's negative, then maybe what we should do is, before we try these expensive medicines, is try a drug like omalizumab or an alternative way of treating their angioedema, looking at the histaminergic pathway first. So we think that this could really be helpful in getting patients to the right treatment as quickly as possible. Let me just say a couple words about our Angioedema Center at UCSD. As I mentioned at the beginning, this is the U.S. Hereditary Angioedema Association Angioedema Center. We work hand in hand with the patient organization in the U.S. who helped us build this center and has really been integral in everything we do. And the results that I just presented to you represent the group efforts of everybody at the Angioedema Center. All of our physicians participated in this. Our nursing staff, the way they collect the blood and process it immediately, everything has to work together. Our patients have been great. The Angioedema Association, the HAE Association, helps send us patients from around the United States so that we get these rare patients. It's really the way that we can drive research forward, and I'm very grateful for the resources we have. And this is a shameless plug that if you know anybody who's interested, a translational researcher, we want to know about it, and if they're interested, come talk to one of us. And so probably more people recognize this movie, which is Amadeus, another great movie set in Vienna. And with that, thank you very much for your attention. Thank you for being here. Thank you for caring. And let's go for the cure, okay? We want a cure. We want total control. Thank you very much.
Good morning, everybody. And I have to apologize because I don't have a real presentation. I put together some of the slides. I was asked, actually, to say what are we doing in our lab in Italy, in Milan, where I worked, and where I've been working since I graduated. So, as you know, we've been working on this disease for many and many years. And yesterday, during the scientific presentation, the scientific session, I gave a little bit of the history of what we've been doing. And the way we've been moving over the several years. I started yesterday, so I saw the first patient back in 1972 when I was a student. And I remember the lady who came, the first one I saw with HAE. And then I keep seeing the same patients since that time. So I'm a very close friend of so many of those patients. And Marco, who talked just before, I know his father since probably 82, I don't remember, something like that. So I feel a little bit part of these families who have been coming to us. There is another one, Monica, who is sitting somewhere here. And so also the research has been something that has been developing with the patients all the time. And many of the patients remember when I was asking them to come and donate blood, and not just blood, and staying hours in the hospital to get data after the infusion to identify how the C1 inhibitor was remaining in the circulation. And then there was one study based on the half-life of C1 inhibitor, and this study had to be done injecting C1 inhibitor, and then patients had to recover, to get blood drawn for a certain period of time, and also urines for 24 hours. And I remember there is Piero Mantovano, who was participating, and you all know is the president of the Italian Association, who was actually going to work at that time, carrying the bottle of the urine at work and back to bring it back. So there has been a lot of things that had been possible, because this gave important information, this study, because we had the first half-life of C1 inhibitor, which is important in order to define how the drug has to be administered, how often has to be given. So this is something that it's really relevant, and it's something that we could do just working next to the patients. And that's why we started with the association, and we've been working with the association all the time for now. The association started in 1980, is 2018, and you can think of how long we've been working with these patients. So over the time, things have changed, of course, and have changed in a nice way, as you can all realize. Some of you may have experienced what was HAE back in the 70s, and there is a lot different. And this is what is the nicest thing that we can say and we can face staying here together. So one of the changes that I faced, and I think now I start thinking in a slightly different ways, because there is angioedema, there are patients with HAE. I started seeing patients with HAE, and these were patients with a very specific disease. And at the beginning, I realized I was just interested on those patients. So saying, well, this is HAE, this is the deficiency of C1 inhibitor, and that's what I'm interested in. And the other patients were similar, but were not really interesting for me. And then I realized that this was a very narrow view, because a disease is something that is much wider than we think. And yesterday I pointed to the fact that the disease per se does not really exist. There are different behaviors from patients, from subjects. So there are subjects who react in one way, there are subjects who react in another way. If you are exposed to a stress, someone becomes completely red. Someone has also some kind of urticaria, and nobody considers this as a disease. It's just a matter of the way a person reacts. And so also the angioedema somehow is something which is similar. And so I don't know how many people, if you take the general population, has had one angioedema during the life. Many. I had one for a drug that was some year ago, many years ago actually. And most of the people had angioedema as an allergic reaction, or sometimes an angioedema without a specific cause. We know that we have patients then when they take some drug, they have some angioedema because of the drug, but there's a small number compared to all the number of patients or subjects who take this drug. So I start thinking of this disease as something that is a variation compared to the normal behavior. So instead of reacting in one way, people who are deficient in a C1 inhibitor, they react with a swelling. And you all know what the story of the swelling. And then there are people who react with exactly the same swelling for other reasons, because they are exposed to a drug, or for a reason that we still do not understand, but it's still a kind of reaction that these people had. And then I came across to another disease, which is, to me, very similar to angioedema, but is a disease where the swelling is not localized. The swelling is a generalized swelling. So these people, at some point, they're perfectly healthy, like you are, most of the time. And then suddenly they start losing the plasma outside from the vessel. So the plasma moves from the vessel into the extravascular space. But since it is diffused all over the body, you don't see that much of the swelling. So the swelling is the main character of HAE. So you see a face which becomes completely different, and this is the swelling that you see. But if you have the same swelling generalized, you don't notice too much. But what happens is that all the plasma goes outside. So the vessel contains cells and contains fluid. And if you move the fluid from the vessel to the outside, you remain just with the cells. And this is what happens to these patients, that they are called to have this idiopathic capillary leak syndrome. You heard one term that you heard before when Professor Zuraw was talking, idiopathic. Idiopathic means that we understand nothing about the disease. That's just a different way to say what we are, no? So we have this idiopathic disease where people leak outside from the vessel all the blood, and they go into a state of shock, a real severe, extremely severe shock. And as for angioedema, they stay with the shock for 36 hours, and everything goes back to normal, perfectly normal, and they start their life normally. So I start thinking that there is a kind of certain number of disease that can be characterized by one situation that we can define as a disorder of permeability. So we have the vessels, and the vessels have a kind of windows that let the fluid go outside and come back inside to feed the tissues. When these windows become wider, then everything goes out and just the cells remain inside. And this is something that does not happen because these vessels are damaged. The vessels are perfectly normal, but they change the function. So instead of having a window which is 1 centimeter wide, they have a window that becomes 10 centimeter wide. And so you can understand it's like if you put water in something which has holes, and everything goes out. And this is what happens. So we have a group of diseases that we call diseases of permeability, and diseases that are paroxystic. Paroxystic means that they happen at once, all at once, and then they recover. And we do not know why this happens. We don't even know for HAE. We know that we have situations that predispose to this leakage, but why? Why today you're doing perfectly and 2 hours later you start swelling? Nobody knows. And the same for the people with the capillary leak. So this is something that I think has some unifying factor. And what we want to understand is what is this unifying factor? You heard already that we have different forms of angioedema. And we distinguish two groups. One where we don't see inheritance. So we just see that these patients have angioedema and they don't have a character that we can link to genetic, at least not directly. And this can still be the acquired deficiency of C1 inhibitor, the patient who take the androgens, and also the patient who have something which is close to an allergic reaction. And then we have forms, again, idiopathic, and this is the majority. No, always, the majority of the field is still not understood. And then we have other angioedema that are hereditary. And most of these are due to the bradykinin. You heard many times about bradykinin. And we have the C1 inhibitor deficiency that starts from a mutation in one gene. And this has been for a long time the only gene that has been related to angioedema. So we identified the term hereditary angioedema with the term with C1 inhibitor, genetic C1 inhibitor deficiency. And then Conrad Bork realized that this was not the case because we had some family. He found some family and studied the clinical aspect of this family, and they were pretty much identical or similar, at least in some respect, to the patient with C1 inhibitor deficiency. And so, moving on and understanding, he found that these families had a mutation in factor 12. And the mutation in factor 12 was leading to the same situation as SERPING1 mutation, C1 inhibitor mutation, with one difference that in this form were almost just women were having symptoms. So if you have this mutation in men, almost nothing happens. It's extremely rare. If you have this in women, this happens. And happens more when they're taking estrogen, when they have a pregnancy. So it's similar, but you need something else. And then in 2017, there were 2 additional genes that were found. One was found in Italy, as is the angiopoietin that you heard, and one again was found in mice by Conrad Bork, and these the plasminogen mutations. So we have an array of mutations that lead to angioedema. And then we have another one, which is the so-called unknown hereditary angioedema. We moved from idiopathic to unknown, but the meaning is exactly the same. So something that we do not understand. So we have this group of diseases. In the other side, where there is the leakage from all the vessels, we know even less than in these patients. So what we know is just that these patients, this subject, they have an increase in permeability because we can study the fluid in the extracellular compartment, and we can see that the composition of the fluid in the extracellular compartment is exactly the same as the fluid in the plasma. Identical. They had the same concentration of proteins, of salts, of everything. And the fluid goes out and stays out until the windows close. When the windows close, the fluid comes back. And people may have very, very severe problems because they may they may have problems for shock, or they may have problems due to the fact that this fluid comes back all at once, and they have cardiac failure. So in this situation, what is that keeps things together? We think that probably the main problem is those barriers that are between one cell that covers the vessel and the other cells. There are proteins that goes from one side to the other. And at some point, this protein open. And when this protein open, everything can flow outside. So what are we studying now? So we're trying to understand what are these phenomena. So what happens to the vessels? Why the vessel at some point have these windows enlarging? There are different factors that act on the vessels. And we are trying to dissect these different factors and study these factors, how they react. All the vessel have kind of receptors that keep the vessel in a certain situation, and these receptors at some point can stimulate. So this is one of the things that we're studying. And the other thing that we're studying is to reproduce the vessel in a chip. So it's a kind of system where you can study the vessels directly and see what happens. And the last point that we are studying is the influence of the autonomic nervous system, because the autonomic nervous system regulates the vascular permeability, and we have tools to study the autonomic nervous system. And in the end, what we can do is to collect all the data so that we will be able to relate with the registry that you heard, the clinical data, the laboratory data, the data that we can record during life. We can record the autonomic nervous system continuously and see if we will come up with the understanding of what's happened to the people who sometimes have an angioedema or may have a leakage from the capillaries. Thank you.